Hi, I'm Dr. Maria Corcoran from the University of Washington, and in this Hepatitis C online mini lecture, I will be reviewing a few key studies on glecaprevir-pibrentasvir. In this lecture, I will provide an overview of glecaprevir-pibrentasvir, which is sold under the brand name of Mavyret, outline key studies supporting the use of glecaprevir-pibrentasvir in patients without cirrhosis, and outline a key study supporting the use of glecaprevir-pibrentasvir in patients with compensated cirrhosis. Glecaprevir-pibrentasvir is FDA approved for use in treatment-naive adults and pediatric patients 3 years of age and older with acute or chronic hepatitis C who have genotypes 1 through 6 without cirrhosis or with compensated cirrhosis. It is also FDA approved in genotype 1 patients who were previously treated with a regimen containing an HCV NS5A inhibitor or an NS3/4A protease inhibitor, but not both. Although not FDA approved for this indication, it is also sometimes used along with other antivirals for the treatment of patients with multiple prior DAA failures, as outlined in the AASLD IDSA guidance for HCV treatment experience. It is important to note that glecaprevir-pibrentasvir is contraindicated in patients with decompensated cirrhosis. Glecaprevir-pibrentasvir is co-formulated into a single tablet that contains 100 milligrams of glecaprevir, an NS3/4A protease inhibitor, and 40 milligrams of pibrentasvir, an NS5A inhibitor. Patients take 3 tablets orally once daily for a total dose of 300 milligrams of glecaprevir and 120 milligrams of pibrentasvir. This medication should be taken with food. Most patients tolerate the medication well, with the most common side effects being headache and fatigue. In treatment-naive patients, an 8-week course of glecaprevir-pibrentasvir is recommended for all genotypes, including in patients without cirrhosis and in those with compensated or Child-Pugh Class A cirrhosis. There are many randomized controlled trials supporting the use of glecaprevir-pibrentasvir for the treatment of genotype 1 through 6 HCV. Here I would like to highlight just 3 key trials that support the use of this drug in common clinical scenarios. The first study is the Endurance-1 trial, which looked at glecaprevir-pibrentasvir for 8 versus 12 weeks in patients with genotype 1 HCV and no cirrhosis. Endurance-1 was a randomized, open-label, Phase 3 trial evaluating the safety and efficacy of fixed-dose combination glecaprevir-pibrentasvir for 8 versus 12 weeks in treatment-naive or select treatment-experienced adults with genotype 1 chronic HCV infection without cirrhosis. Key eligibility criteria included having genotype 1 chronic HCV, being 18 years of age or older, having an HCV RNA of greater than 1,000 international units per ml, being treatment naive or having previous treatment experience with PEG interferon with or without ribavirin and sofosbuvir. Patients with cirrhosis were excluded in this study, as were patients with chronic hepatitis B, but patients with HIV co-infection were allowed. The primary endpoint was achieving a sustained virologic response at 12 weeks. A total of 703 patients were enrolled, 351 randomized to the 8-week arm, and 352 randomized to the 12-week arm. All received 3 pills of glecaprevir-pibrentasvir once daily. Baseline characteristics were similar across groups. The average age was 53 in the 8-week arm versus 52 in the 12-week arm. Approximately 50% of patients in both arms were male and 4 were Black. Over 40% of participants in both arms had genotype 1A, and the median HCV RNA was 6.1 logs. 85% of patients in both arms had F0 or F1 fibrosis, with only 9% in the 8-week arm and 8% in the 12-week arm having F3 fibrosis. 28% of participants across both arms had a history of injection drug use, and few were co-infected with HIV. In the primary subset analysis, which excluded persons with HIV or previous sofosbuvir treatment, over 99% of participants in the 8 and 12-week arms achieved an SVR12. In the per-protocol analysis, which excluded patients who prematurely discontinued treatment, had virologic failure before week 8, or who had no HCV RNA value assessed, 100% of participants across both arms achieved an SVR12. Among patients without HIV co-infection, greater than 99% in the 8-week and 12-week arms achieved an SVR12. All patients with HIV and HCV co-infection in this study achieved an SVR12. Collectively, the results of Endurance 1 showed that once-daily treatment with glecaprevir-pibrentasvir for either 8 weeks or 12 weeks achieved high rates of sustained virologic response among patients with HCV genotype 1 infection who did not have cirrhosis. Endurance 3 was a similar trial evaluating the efficacy of 8 and 12-week treatment courses of glecaprevir-pibrentasvir in genotype 3 patients without cirrhosis. This study was published alongside Endurance 1. Endurance 3 was a randomized phase 3 trial evaluating the safety and efficacy of the fixed-dose combination of glecaprevir-pibrentasvir for either 8 or 12 weeks in persons with genotype 3. Specifically, patients with genotype 3 infection were randomly assigned in a 2-to-1 ratio to receive 12 weeks of treatment with either glecaprevir-pibrentasvir or sofosbuvir-decladisvir. Additional patients with genotype 3 infection were subsequently enrolled and non-randomly assigned to receive 8 weeks of treatment with glecaprevir-pibrentasvir. Key eligibility criteria included having chronic HCV genotype 3, being 18 years of age or older, having an HCV RNA greater than or equal to 1,000 international units per ml, and being treatment naive. Participants were excluded if they had cirrhosis, HIV, or chronic hepatitis B. The primary endpoint was SVR12. The trial enrolled a total of 505 patients. 233 were randomized to 12 weeks of glecaprevir-pibrentasvir, and 115 were randomized to 12 weeks of sofosbuvir-decladisvir. An additional 157 patients received 8 weeks of glecaprevir-pibrentasvir. Baseline characteristics were largely similar across groups. The average age was in the late 40s. Between 45% and 59% of individuals were male, and 2 to 3% were Black. Nearly 2/3 of participants in each arm had a history of injection drug use, and the average BMI was 25 to 26 across arms. Median HCV RNA was 6.0 to 6.1 logs, and greater than 90% of participants in each arm had HCV subtype 3A. Notably, a higher proportion of patients in the 8-week glecaprevir-pibrentasvir arm had F3 fibrosis than compared to the other 2 arms. In the intention to treat analysis, 95% of participants in both the 8-week and 12-week glecaprevir-pibrentasvir arms achieved an SVR12. By comparison, 97% in the 12-week sofosbuvir-decladisvir arm achieved an SVR12. Very few participants experienced virologic failure. This occurred in less than 2% of participants in the 12-week glecaprevir-pibrentasvir arm, less than 1% in the sofosbuvir-decladisvir arm, and in 3.8% in the 8-week glecaprevir-pibrentasvir arm. Loss to follow-up occurred in 1 to 2% of participants across all arms. When stratified by baseline polymorphisms, greater than 90% of individuals in the glecaprevir-pibrentasvir arms achieved an SVR12 when they only had an NS3 or NS5A polymorphism. However, SVR12 rates were lower, 86% in the 12-week arm and 71% in the 8-week arm, when participants had both an NS3 and NS5A polymorphism at baseline. Those without baseline polymorphism mutations had SVR12 rates approaching 100%. While most participants across arms experienced at least one adverse event, the incidence of serious adverse events was only 2% across all arms, with 3 patients in the 12-week glecaprevir-pibrentasvir arm, 1 patient in the sofosbuvir-decladisvir arm, and 0 patients in the 8-week glecaprevir-pibrentasvir arm discontinuing study drug due to an adverse event. Overall, adverse events were mild and most commonly included headache, fatigue, and nausea. Laboratory abnormalities were rare, with only 1 grade 3 or above abnormality in each arm. Collectively, the Endurance 3 trial showed that once-daily treatment with glecaprevir-pibrentasvir for either 8 weeks or 12 weeks achieved high rates of sustained virologic response among patients with HCV genotype 3 infection who did not have cirrhosis. The third study I would like to highlight is Expedition 8, which looked at the use of glecaprevir pibrentasvir in persons with genotype 1 through 6 and compensated cirrhosis. Expedition 8 was a single-arm, multi-center phase 3 trial evaluating the efficacy of 8 weeks of glecaprevir pibrentasvir in treatment-naive participants with genotype 1 through 6 chronic HCV and compensated cirrhosis. It was performed at 94 international study sites. Eligibility criteria included being 18 years of age and older, having compensated cirrhosis diagnosed by biopsy, FibroScan, or FibroTest plus APRI, having an HCV RNA level of 1,000 international units per ml at screening, being treatment naive, and having a Child-Pugh score of 5 or 6 consistent with compensated cirrhosis. Persons with HIV or HBV co-infection and those with current or past decompensated cirrhosis were excluded. The primary endpoint was sustained virologic response at 12 weeks after treatment completion. All patients received oral glecaprevir pibrentasvir once daily for 8 weeks. Plasma samples for determination of HCV RNA levels were collected at screening, at regular intervals during the treatment period, and at post-treatment weeks 4, 12, and 24. 343 participants were enrolled with a mean age of 58. 63% were males, 83% were white, 8% were Black, and 13% were Hispanic or Latino. 90% had a baseline Child-Pugh score of 5, 10% had a baseline Child-Pugh score of 6, and less than 1% had a baseline Child-Pugh score greater than 6. The median HCV RNA level was 6.3 logs at the time of enrollment. 67% of participants had genotype 1, 8% had genotype 2, 18% had genotype 3, and few had genotype 4, 5, or 6. Baseline NS5A polymorphisms were present in approximately 1/3 of the sample, but most participants had no baseline resistance-associated substitutions. Among the participants enrolled, 83% had cirrhosis determined by FibroScan. For this study, a FibroScan cutoff of 14.6 kilopascals was used, which is slightly higher than what is currently used in clinical practice. The remainder of participants had cirrhosis determined by either histology, meaning a liver biopsy, or by having a FibroTest score of 0.75 or above and an APRI score of 2 or above. In the intention to treat analysis, 97.7% of participants overall achieved an SVR12. When broken down by genotype, patients with genotype 1 had a 97.8% SVR12 rate, and everyone with genotype 2, 4, 5, and 6 achieved an SVR12. The SVR12 rate for those with genotype 3 was slightly lower at 95.2%. However, 2 of the 63 people in this subgroup were not counted as achieving an SVR12 due to missing data. In the per-protocol analysis, 99.7% of participants achieved an SVR12, 100% in the genotypes 1, 2, 4, 5, and 6 groups. There was one participant in the genotype 3 group that experienced a viral relapse at post-treatment week 4. This individual had a relevant medical history of chronic pancreatitis, duodenal gastric reflux, and cholecystectomy. Although this patient was adherent to study drug administration determined by pill count, their observed glecaprevir and pibrentasvir trough plasma concentrations were numerically lower throughout the treatment period compared with the median trough concentrations in all genotype 3 infected patients with compensated cirrhosis, as well as in patients infected with other genotypes. The altered gastric motility and reduced pancreatic exocrine secretion was postulated to have impaired the absorption of glecaprevir pibrentasvir in this patient. The patient did not have any baseline polymorphisms in NS3 or NS5A. Adverse events were relatively uncommon in this study. There were 6 serious adverse events, but none were deemed to be drug-related, and none led to treatment discontinuation. 9% of patients experienced fatigue, 8% pruritus, 8% headache, and 6% nausea. There were very few grade 3 or greater laboratory abnormalities. Collectively, this study showed that 8 weeks of glecaprevir pibrentasvir was well tolerated and led to similarly high SVR12 rates as the previously studied 12-week treatment course in treatment-naive patients with chronic HCV and compensated cirrhosis. To learn more about hepatitis C, please check out our online hepatitis C curriculum, which contains a variety of lessons, cases, and slides to reinforce your knowledge. Thanks for joining me today.
The production of this hepatitis C online mini-lecture was supported by a cooperative agreement from the Centers for Disease Control and Prevention, CDC, RFA, PS 212105. This project is led by the University of Washington Infectious Diseases Education and Assessment Program.